I hope everyone is good. You are preparing well for your exam. Okay, so only 10 people have joined. From September date, only 1, 2, 3, 4, 5. So that shows your seriousness, and when you will fail, you will say that we were well prepared, but we failed. So only 20 to 25 days are left. You must be serious, you must work hard, you must leave everything, focus on your exam. If you will pass it, voice is not clear. Anyone else? Anyone else? Doctor. Clear, I think it's on your side, Dr. Anna. Voice is clear. You checked your own network. Okay. So I was talking that you must work hard and you must do the smart study. Focus on resuscitation, procedure skills, trauma, cardiology, and SLO1, PEDS emergency, respiratory, IENT, toxic. That you must revise, that should be on your fingertips. You must not miss a single MCQ from these. And also go through other topics which I have mentioned. So other topics you must go through the quick revision notes that you can go through. So that would be a smart study. And also go through the topics like I mentioned about the quizzes. So you must not focus on the MCQs, okay? You must focus on topics that previously we have done about 7 to 8 quizzes. We discussed the topics. I discussed topic with you. Quick notes, Annie, I have shared quick notes with you. You have made your own quick notes. Either I will tell you that how, other than these topics for SLO1, how you can do a quick revision for other subjects, like if you are going to do the infectious disease, how will you do that quick revision from the MCQs, how to pick it, and that I will tell you at the end of session. So today, as we have discussed in detail the cardiology, so I will not teach you the theory. I will teach most focus on MCQs. Okay, some MCQs from here, some from the MRCEM success PDF, and then I will also give you a quick overview. So acute coronary syndrome, we already discussed in the resuscitation. There can be ST segment elevation, non-ST segment elevation. So you must go through it. You must also, that's the history taking. That's not important in MCQs, but important if either is in the exam, they will give you the ECG, you have to pick it. I have shared that you must focus on 12 ECGs, 12 ECGs for SBA and 12 ECGs for MRCP. You may not miss any ECG. Nothing out of these ECG will come. Okay, so all the ECGs which will come in the exam, either in the MRCP, either in the MRCP SBA, they will be in from these 12 to 15 ECGs. Okay. So most likely that is the radiation to right arm and shoulder that you must know, and to both arm. That's also most likely. Least likely that is pleuritic, positional. Okay, sharp. That are decreased likelihood that will for the in history taking. Ischemic ECG changes. So these are clinically important, and that you. But at this time you must not focus on this. So I will give you the only as there any important point, then I will mention it. So that is localization of lesion. STEMI, I have told you about the formula, that how you must remember about it. SALE from V1, V2, V3, V4, V6. So that's how you must remember. S for septal, A for anterior, L for lateral, and then A for anterior, septal, anterior, lateral. Okay. So that's S for septal mean V1, V2, anterior mean V3, V4, lateral mean V5, V6. So in lateral wall, always remember, so what will happen as it is an L, so there will be AVL lead involved, 1 and AVL. So F inferior, F, there is a F, so that's how you can remember there will be depression ST segment elevation in the F, and reciprocal there will be on the lateral. I will tell you that how you must remember the reciprocals. And posterior, there will be involvement of the posterior leads. So that's how you must remember. Other thing that quickly we go through the blood supply that I told you about, the rest in peace. R mean right coronary artery, I mean inferior wall, P mean posterior wall. So right coronary artery, that if there is any involvement of inferior posterior, that means right coronary artery involved. And for lugs, I told about lugs, that mean lateral and left circumflex artery. So that's how you can remember lugs for lateral wall MI, lugs. Anything other that will be left anterior descending artery. So immediate, we will do the monotherapy and morphine, oxygen, and nitrates and aspirin. That's what we are going to do. If you are suspecting on, you are going to do these 4 things immediately. You are going to give the morphine for pain relief. Any opioids you can give, and oxygen, nitrates, and aspirin. That's if patient is hypotensive, then we will not give the nitrates. So other, if there is STEMI, that you must remember, we will move the patient for PCI within 120 minutes. If PCI can't be done within 120 minutes, okay, then what are we going to do? If PCI can't be done within 120 minutes, then what are we going to do? Fibrinolysis. Okay, so that's what we are going to do. If patient is waiting for PCI, so between that you can also give the clopidogrel, that you must remember you will give the 600 mg. Okay, so that should be your plan. Either you can give the tecagrelor, that is 180 mg. So that's how you must remember. Next is the fibrinolytic therapy. After administration of fibrinolysis, you must do the ECG within 60 to 20 minutes. Then is the NSTEMI. NSTEMI, same, you will give the monotherapy, and then the other thing, if patient is going for the, if main important thing that will come in the exam, NSTEMI and hemodynamically unstable. Okay, so then you will also go for immediate PCI. Okay, angiography you will do the immediate if patient is hemodynamically unstable with NSTEMI. That's also you must remember. Antithrombin therapy, that is fondaparinux, that patient is not going for angiography within 24, you can give the fondaparinux or heparin, that you can give risk score, clopidogrel, that is loading dose of 300 mg in NSTEMI. So these are risk. Heart score is very important in it, that you must remember about the heart score, history, ECG, okay, and H for history, E for ECG changes, A for what is A for, you must all know there is one MCQ from the heart score, that's very important.
A for age, T for
Yeah,
troponin,
okay, and R for
risk factor.
risk factors. Okay, so if the score, when you will discharge the patient, that's very important in heart score, when you are going to discharge the patient. I have shared in the group, mild, when you will say that it's mild case, which score? 0 to 2 or 0 to 3? That is 3. Okay, always remember that is 3. 3, you will discharge the patient. 4 to 6, you will admit for observation. And 7 to 10, you will go for intervention. Okay, so that's very important to remember. And in the exam, most of the time they have asked about which is not a part of hard score. That's also important. uh, if anyone have the previous, I have shared the screenshot for hard score. You can share in the group. I will share with further groups. So hard score: history, highly suspicious, moderately suspicious, slightly, then the ECG, significant ST depression. This is not a time to teach you the theory. I think you must, you are going for December diet. You must know these things, okay? Because I should only discuss the MCQs, not to teach you the theory. You must answer quickly. So when you will give the 2 points, at which age you will give the 2 points? Quickly. 65. Okay, 65 more, 65 or more than 65 will give 2 score. Risk factor, that was very important. Which risk factor you will include in it? 3 or more risk factor, then you will give 2. 1 or 2, give 1. Not only atherosclerosis. Okay, there are many risk factors. Out of these, 3 are present, you will give 2 marks. 1 or 2 present, you will give 1. Nothing, then you will give 0 point. Okay, hyperlipidemia, hypertension, family history of coronary artery disease, smoker, so diabetes, okay, obesity. That's you must remember. And troponin, that's also when you will say that it's significant when it is C for the upper normal limits. Okay, 3 times the upper normal limits. Normal limits, that's you must remember. So hard score is very important in the cardiology. Okay, hence secondary prevention. So that we will give the aspirin daily for life, and clopidogrel or Tacogrel we can give for 1 year for patient. That depends on the condition. So that's different in different patients. Okay. Other thing, ACE inhibitors, that is we give it for reduced remodeling that contributes left ventricle dilatation impairment. That's these functions you must remember. These are from MRCEM success. Beta receptors, treatment with beta blockers started early, that has been shown to reduce the mortality. That you must remember. These are the important things. Posterior marker we have discussed. And the V1 is there will be ST depression. So in the inferior leads, posterior reciprocal ST depression will be in the inferior lead. So that's the MCQ. Call it, and then we will move on. You can't see the slide? Okay, just what happened. Okay, now you can. So let's type the unstable angina. Okay. So that is pressure like chest pain, ST segment depression, and negative troponin results. If it was positive results, then what would be your management plan? Yeah, and STEMI. Then how will you manage this patient? Yeah, first you will give the monotherapy and you can discharge the patient. And what are you going to do? You will keep under observation and you will do the serial drop, check the trend, you will start the anticoagulation, you will check the trend of troponin. Okay, that's what should be your plan and stand case of and stem. If patient is hemodynamically stable. Okay, what you can see? Tell me the type, which type of MI it is. The inferior wall. Inferior will wall have reciprocal ST depression on which leads? AVL. Okay, so you must remember PI. PI. Okay, so that PIL. So that's posterior will have reciprocal on inferior wall, inferior will have on lateral, lateral will have on interior. So that's how you can remember the reciprocals, PILA. Okay, so that's how that posterior wall MI that will have reciprocal on inferior leads, inferior wall MI that will have reciprocal on L mean lateral leads, and lateral wall MI that will have reciprocal on interior leads. So that's how sequence you can remember. Okay, so what would be which coronary artery involved in this case? Inferior wall MI, right coronary artery. Okay, so how will you manage this patient? What is your definitive management plan? Definitive PCI. Okay. Okay. If PCI patient is waiting for the PCI, okay, patient waiting for the PCI, and patient deteriorated. Okay, patient deteriorated, and patient is nurse has called you that patient is deteriorating. Patient is feeling shortness of breath. Patient is feeling shortness of breath, and there is already PCI is ongoing. Okay, PCI is already ongoing in the cath lab. Cath lab is busy. What would you do now? Airway is patent. What would you do now? Patient can't, patient is waiting for PCI. Okay, good. So you will start the fibrinolysis. Okay. So you will start the fibrinolysis, but patient is feeling shortness of breath. So will you do anything? Yeah, you will do the fibrinolysis. You have examined, and on the examination there are crepes. Why diuretics you are starting without any evidence? You will okay, you can do the x-ray. Okay, so there is a pulmonary edema and patient is in a shock. Now patient is in a shock. So blood pressure is 80/40. So what would be your management plan? Chest X-ray finding showing pulmonary edema.
Fluid? Can we give fluid? Sorry.
In chat box, please, in chat box. Okay, patient is in a shock. So yeah, good. So pulmonary edema, there is patient is in a shock. So what type of shock this is? Cardiogenic shock. So you will start the inotropic sport because you can't give the fluid. Already fluid overload or pulmonary edema has developed. Patient is in a cardiogenic shock with pulmonary edema. So what's happened? So now what will you do? You will start the inotropic sport. Which inotropic sport you will start? And you can also, with inotropic sport, you can start the diuretics infusion, that the furosemide infusion. You can give the stat dose 80 mg, then you can start the infusion. That should be your plan. Okay. That was an ASCII case. So that's also can be asked in the SBA and a different theoretical question that you must know that question can be asked in anywhere. Okay, next. Okay, so what are the ECG findings? Okay, so there was ST depression. So we will check the posterior leads. Okay. Because we discussed previously, Dr. Bushra, I think my internet is unstable. I'm audible. Here we discussed, okay, that V1, V2, these are the reciprocal for the posterior leads. There will be ST depression on these leads, okay, V1, V2, V3. And for inferior, there will be reciprocal on lateral, and anterior lateral, that will be reciprocal on inferior leads. So that we discussed, I think, wrong. That we can make it right. So that's would be formula. Posterior on the anterior leads, okay. V1, V2, V3. Anterior chest leads. Anterior lateral, that would be on the inferior. Inferior will be on the lateral. I think that that time I told about the wrong abbreviation. Okay, so that's you must remember. That's why we are checking the posterior leads. Okay, next question. Sorry. Yeah, to see these are reciprocal lead to see the original leads.
चाय अच्छी है यार.
Okay, so question is tight band, chest band of pain across the central of the age history of ischemia, currently smoker. On examination, he is currently pain-free, following intravenous morphine sublingual. Normal limit ECG shows ST segment depression and leads V3, V4, while there are no ST segment changes. Still, which of the following statement is correct? So that's diagnosis ST elevation myocardial infarction. That's not, because there's no ST. Primary PCI would be indicated if a troponin result. So we can't go for the troponin on the basis of it, as there is no indication for ST elevation. The diagnosis unstable angina. So okay, we keep it in our option. Diagnosis un-ST elevation myocardial infarction. So there is okay, so that's not on-ST elevation myocardial infarction has a worse long-term prognosis. Then why it is have a long-term prognosis? Because we will if there is that was ST elevation, we directly go for PCI. But it is un-ST elevation, so that's why that have a worse long-term prognosis, because there can be mortalities. We take it light, so that's can happen. Okay, that's why it's the long-term mortality is worse in NSTEM, and short-term that is for the STEM. Next question. Okay, so which of the following that's reduced mortality? Reduced mortality is related to beta blocker. I told you 3 minutes ago, 3 to 5 minutes ago. So other thing that I think we discussed in the resuscitation algorithm, we were discussing the myocardial infarction and STEMI. Patient is presenting within 12 hours of symptoms, okay? Symptoms. Then we will offer the sphenolysis if PCA is not possible within 120 minutes, okay? That you must remember. In the rhythm that you can also go through. Anyone have read through the RCM learning for this and STEMI? Anyone have read myocardial infarction from RCM learning? Yeah, good. So that's very important. You must go through. That's the question I told you about the pulmonary edema complication. That's also given there. Okay. So that's why you must go through. The people who are going for January diet. Okay, 2 hour history of central chest pain, ST elevation, lead 2, 3 AVF. He has a post-medical history of peripheral vascular disease, poorly controlled type 2 diabetes. He is a current smoker. Nearest primary PCA center is 3 hour transfer away. Which of the following management plan is most appropriate? Yeah, so you can't do the PCI within 120 minutes there, and the symptoms are within 12 hours. That's why we will go for fibrinolysis. That's what we discussed now. Next, so there are variety of answers. 1E, 2E, A, E. So that's a normal sinus rhythm with inverted T wave in lead 3 and AVR. Is there any significance of T wave in lead 3 and AVR? Taken at triage is positive. What is the recommended next step of this patient? As a troponin positive, so what will we do? So patient, so what apply on this? I told you about this. What will you apply? Which score you will apply? We discussed. Okay, Dr. Bushra, can you explain why will you go for venolysis? Okay. Yeah, good. So because it is a high risk patient, so that's why drop is positive. Yeah, good. So that's why we will go for venolysis. Yeah, so heart score is also high. We will keep under observation and gray score. So that's why we are not going to discharge this patient. Okay. So we will do the serial troponin level. The patient is having risk factor, age. So that's why according to heart score, TIMI, so that's why we will go for the serial drop for this patient. Although T wave inversion in lead 3 and AVR that are not significant. Okay, they are not significant if you find in any ECG. Heart score, that's what we have discussed. Okay, 0 to 3 low score, 4 to 6 moderate, and 7 to 10 high score. 0 to 3 we will discharge, 4 to 6 we will admit and observation, 7 to 10 we will consider the intervention. That's the common question have been previously asked many times, which is falling is not a part of heart score. Okay, so you must remember all the risk factors in the exam they can give. All the risk factors they can ask which is part of heart score, either they can ask which is not a part of discharge criteria, admission. So that's you must know everything about the heart score. Okay, Rosier score, heart score, these are very important. Well score for DVT, for PE. So these scores are important. Other score, Wesley score for a group. So So these are very important. Okay, you must not forget about. Okay, the ECG for the Brugada syndrome, that's very important and it has been asked many times in the exam. So I have shared the list of 12 ECGs. So which other disease that have a sudden death, high incidence sudden death in young patient with the Brugada outcome? So you must suspect both if there is a sudden death. Okay, so that's you must remember. That will be COVID ST elevation. So that you can see COVID shift ST elevation. That's very important. Remember by negative T wave. So there you can see the negative T wave. It's called the Brugada sign. Okay, how will you manage this patient? Yes, you will go for ICT. Good. So also you must remember the management plan. Nowadays they are asking a lot of management. That's the type 1. Type 2 is have a peritoneum of saddle back shaped ST elevation. That's also you must know about this. Valence syndrome, that in Valence syndrome, that will be biphasic or deeply inverted T wave and V2, V3. So that's you must know about the ECG of Valence syndrome. Pattern A, pattern B. Here you can see biphasic T wave. Okay, so there are two phases, positive and negative. That is a deeply inverted T wave in the current pattern B. Cardiac failure, you must know about the cardiac failure. There will be enlarged heart on the X-ray. Okay, breathlessness, apnea, fluid retention, third and fourth heart sound, raised GVP. So that's the cardiac failure. You must know. Acute heart failure investigation, you can go for echo. That's very important. Okay, so echo is very important in the cardiac failure, acute heart failure, pulmonary edema. Pro BNP, you can go for it. Chest X-ray. On chest X-ray, you will find this is the pulmonary edema chest X-ray. Curly B, septal lines, bad swing, highlight shadowing, fluid internal lobar fissure. So that's cardiomegaly, pleural effusion. So that's you must know the X-ray. So we will give the diuretics, oxygen, okay, bed position. That's these things are very important for the heart failure, pulmonary edema patients. If patient is in a heart failure, that I told, I give you a scenario with cardiogenic shock, then we can consider inotrope vasopressor. We will do the ABGs. If there is carbon dioxide retention, anything, type 2 respiratory failure, we will go for the non-invasive ventilation. That's very important. If there is no response to diuretics, the diuretic resistance, then we can go for the ultrafiltration, hemodialysis, CRT, okay? So if patient can't tolerate, patient is hypotensive, uh, and you can't get the, you can't go for the conventional hemodialysis, then you will go for the CRT, continuous renal replacement therapy. So that's procedure plan. Okay, next question. Okay, so that is which type of failure is this? Type 1, type 2? Type 2. So there is a hypoxemia and hypercapnia, so that's called type 2. So we will start the non-invasive ventilation. And I. Next is infective endocarditis, acute that will happen days to weeks, and subacute that will happen weeks to months. So that's not important. The important thing in remember is organisms. That's native valve endocarditis. These are viridins group streptococci. Okay. Intravenous that you must remember Staph aureus. Tricuspid valve that is most commonly affected, and dental extraction that you must remember for the dental that is Streptococcus viridans. For dental procedure, that's also Streptococcus viridans. That you must remember. These 3 to 4 things you must remember about infective endocarditis. And symptoms: Jane lesion, ostenodes, splinter hemorrhages, raw spots. That's also you must remember. They can ask about which of the following is not sign or symptoms, and for the infective endocarditis. So if there is you are suspecting patient as IV drug abuser, so you must go for, there is a bacteremia, Staph aureus, anything, you must go for the echo to check the vegetations. Okay, for infective endocarditis. When native or infective, you must go for the transthoracic echocardiography. So if negative, but you are suspecting still the infective, then you can go for the transesophageal echocardiography. So next question. Yes, we will. You are suspecting infective endocarditis and IV drug abuser. You will go for transthoracic echo. Okay, that is IV drug abuser, step 4, yes. So what would be your antibiotics? What antibiotic you will give? Gentamicin? Why? In this patient. Fluoxetine, okay. Fluoxetine, we can give fluoxetine. We will give step 4, yes. That's you must remember. For step 4, yes. I don't know, but it's written in box. That's it's used in UK, fluoxetine, okay. But we also give the vancomycin. That's very important in for MSR, Vancom, our country. It is also we are giving girls. That's when we can give 20 mg per kg loading dose. Then we can start the 15 mg. Okay, patient with known cardiac valve disease present to the ED with fever and shortness of breath worsening over the past 2 weeks. Examination, you note poor dental hygiene. The patient informed you he underwent a tooth extraction about. So what is the causative pathogen for this? That's the tooth extraction. That is Veridon. So arrhythmias, that's all we have discussed. Okay. So I am leaving this topic. We have discussed about the resuscitation. The next is the WPW syndrome. That's caused by sudden, rare cause of sudden cardiac death. It is atrial event. There's the accessory pathway in this syndrome that will call the pre-excitation of the ventricle. So that will cause the short peer interval, wide Cuirass complex, and delta wave. So that's delta wave. That's very important. Previously, that have been asked in the exam. So you can see the delta waves. In which leads you can see the delta waves? These have been asked previously. Okay. Okay, good. So you must know the delta waves. So that's other heart blocks we discussed in my previous session. I told about heart block, first degree block, that prolongation of the peer interval. Second degree, that is a progressive lengthening of the peer interval. If it is 4 boxes and one lead, other there will be 5, other there will be 6, 7. So there will be progressive lengthening of the peer interval. So in the second degree, there will be intermittent dropping of the ventricular conduction. Going on, there will be drop of Cuirass complex. Type 2. That is type 2 and 2. There will be P wave not conducting to ventricle. There will be normal 2 and there will be drop. So that's third degree AV block. Complete dissociation between atria. Atria is beating on its own, ventricle is beating on its own. Okay. So atria has its own rate and ventricle has its own rate. So we will calculate atrial rate and ventricular rate in this. But other thing, that the trick I told you about that, next it will come, I told you on the ECG. How will you differentiate? That's this ECG I told previously. So that's here you can see that there will be lengthening of the peer interval. That is 6 boxes everywhere, but here 4, 5, 6 progressive. That type 1, type 2. So you can see drop of Cuirass complex, drop of Cuirass complex, drop of Cuirass complex. That's normal. But here you can see atria is beating on its own, ventricular is beating on its own. But if you will see that I told you a trick, here you can see there is no sequence between the Cuirass complex. Here it is coming after 4 boxes. Here it is coming after 6 boxes. So that's same here. But in this complete hard block, you will see that there will be a sequence, okay? That if you will see the distance between the QS complex from here to here, that's the trick, okay? To differentiate quickly when you are attempting the MCQ, either you are in the OSCE exam. So these ECGs also asked in the OSCE exam. That ECGs I have already told you about. Tachycardia, bradycardia, any bradycardia, AFib, okay? SVT, VT, VFib, and PE. Then the next is the Brugada, STEMI, and STEMI, MIECGs, ACS, then blocks, type 1, type 2, Mobis type 1, type 2, then the type 3 complete heart block, and the other Brugada, HOCM, that ECG, WPW syndrome, Wellen syndrome, other ECGs I have forgot. So I have shared the list, must go through it. So here I will telling about the complete heart block. So that you can see these are regular in according, but they are not cooperating with the atria. There is no association between atria and ventricle. So that's the complete heart block. Okay, next is the bifascicular and trifascicular. Yeah, these two ECGs I forgot to mention. That's also you must remember. Trifascicular block and bifascicular block. So in the bifascicular block, what will be not present from this trifascicular block? First degree heart block. Okay, so what will happen? There will be right bundle block, left axis deviation. That's called bifascicular. If there is an involvement of first degree heart block, that means peer interval, lengthening of the peer interval, then it is called trifascicular block. Right bundle, left axis deviation. How will you see the left axis deviation and right axis deviation? And which leads you will see for deviation? Yeah, one AVF. So positive leads, okay, and then AVF. This is a negative. So that's how. If there is a positive in the one, negative in the AVF, that's called the left axis. If that both are above, that's called right normal axis. If both are below, that's called extreme axis. If it is negative here, okay, and positive here, then it is called right axis deviation. You must remember about the trifascicular block, okay? So there will be right bundle branch block. So that would be M pattern in the V1, okay, and W pattern in the, you can see this is the W pattern in the V6. That's called a RM for right bundle branch block. So opposite, that would be opposite to each. If you remember the one RM, so the opposite will be for the left bundle branch. So what will happen in the left bundle branch? There will be W pattern in V1 and M pattern in V6. That's very simple question. Which of the following is not an adverse feature that would indicate treatment with atropine and cardiac pacing? Yeah, you know, palpitations. So that's also very easy. That was lab setting feature of bradycardia. That's why we'll go for atropine. So what's your diagnosis? That's a complete heart block. So the formula I told you. So here you can see QS complex is here, QS complex, QS complex, QS complex. But there are atria there have their own rate. If you see QS complex, they are on the same distance. They are so regular. So that's but the atria and ventricle they are not associating with each other. They are beating on its own rate. What's that? Yeah, so that is Mobis type 2. Okay. So you can see there is chaos complex, but there is a drop. First there two, one drop, two, one drop. So that's you must not miss these ECGs. And what you can see, how SPT is narrow complex. You can see the narrow complex, Dr. Amna. These are monomorphic. Monomorphic means same voltage. So these like the here, they are monomorphic, but here you can see polymorphic. Okay, so that's not polymorphic. Okay, so what is the treatment? Why you are going for defib? Is there any features given for defib? Magnesium sulfate. Okay, if there is no life-threatening features, we will not go for. So that QT, which tricyclic antidepressants, okay, that can call the QT prolongation, macrolides, ciprofloxacin, that you must remember, and azoles drugs that also can cause QT prolongation. And the other drugs that you must remember the drugs, electrolyte imbalance, magnesium, you must check the electrolytes. Magnesium sulfate 2 gram IV or 10 minutes. So that should be advanced feature. We can go for synchronized cardiovascular. So what's that? No, you know. Yes, it's SVT now. Okay. Supraventricular tachycardia. So what is the first line treatment? If it is stable, modified with the sulfamino. Okay, then what will you give? Adenosine 6, 12, and 18. What are the contraindication? I told you then we will not give the adenosine. Then we will go for second line agents. What are the contraindication? COPD asthma. Good. So what are the second line agents? If patient is having asthma, then what will you give? Verapamil. Okay. You will not give the beta blocker too. That's also called the bronchoconstriction. So you remember what is the dose of verapamil? Dose of verapamil? Yeah, 2.5 to 5. You can give 5. Okay, so that's the okay. Next MCQs. So that's unstable. So that's why we will go for synchronized DC conversion. What's the diagnosis? Okay, so is there any life-threatening feature? No life-threatening feature. So that's why we will go for chemical cardioversion. Okay, next. So that ECG, I think we should give the ECG here. I imported ECG. That was Mobis type 2. So in the algorithm, if you see, there was no life setting features, but if any four things, that what was the four things present, then we will also give the atropine. If there is no life setting features, but on ECG, if there are four things, what are the four things that are present? Yeah, recent asystole, Mobis type 2, complete heart block, ventricular pulse greater than 3 seconds. Then we will go for, yeah, good. Next question. So in this case, patient is bradycardic, but there are no life-setting features, no changes on the ECG. That way we will observe, okay? So don't worry if patient is bradycardic. So that's what happened. There's no risk factor, no life-setting features, so you have to observe. Don't worry about it. Don't be panic. Mobis type 1, not. That was, wait, what are you saying? That was prolonged period. That was type 1 block. Okay, type 1 block, we don't do anything. We only observe the patient. Okay, so four things I told. Mobis type 2, complete heart block, recent asystole, ventricular pulse greater than 3 seconds. For life-threatening features, syncope, shock, heart failure, MI. Then these four and four others, 8 things are present. We will go for atropine. Okay. Okay, next. Okay, what's your diagnosis? Why you are saying that it's AFib? What thing? Complete heart block. Okay, so maximum of atropine have been given. So that's why we will go for next external pacing. Okay, external pacing, you have started the current from 30 joule. Okay, and still you see the pacing current is here. So what will you do? What will be your next step? Okay, so you are increasing the current. No, the pacing is here. Okay, so what will be your next step? Why you are increasing the pacing. Okay, from here at the 70 joule, you have got the pacing here. Okay, here. What's your next step? I have told all these things. No, why are you changing the position? Why are you changing the position? When you, what's that? What does it mean if you are seeing that pacing is here? That is called a, you have got the electrical capture. Okay, when it is following the QRS complex, okay, before QRS complex, that means you have got the electrical capture. So what will you do now? What's your next step? Unsatisfied. I have told a lot of time. Okay. Yeah, excellent, Dr. Hafsa. We will check the mechanical capture. That means we will check the pulse. So these are the common questions that would be asked in the exam. You must not miss it. So atrial fibrillation, we have discussed. Chadwick score, that's S-blood. Now we do the Orbit score, that to check the bleeding. That's the advanced new score. We go for it. Patient with life-threatening hemodynamic instability, we will go for electrocardioversion. Without life-threatening hemodynamic, offer rate rhythm control if onset is less than 48 hours. Start rate control if it is more than 48 hours. We only give start the rate control beta blocker at the junction. Both we can use. Okay. If there is any heart disease, patient is in a shock, beta, patient is in a bradycardia. So that's sorry, patient, we will not start. Patient is having asthma, anything, any contraindication to beta blocker, we will give the digoxin. That's what should be. Rhythm control strategy. If there is structural heart disease, anything, we will go for amidron. Either we can also give the flecainide, but most of the time we go for amidron. Okay. Rate control, beta control, calcium channel blocker, that is person stroke risk, go for the modified Chadwick score. Anticoagulation, we check the Orbit score. Anyone have read my notes? What the abbreviation I told to remember the Orbit score? If anyone have read that, you may know it. Always say, please share your notes, please share, and no one read it because you don't have a time. You must give at least 8 to 12 hours on daily basis, 12 hours to pass the exam. If you want to pass the exam, okay? Just wake up early in the morning, say prayer, start studying, do breakfast, start studying, tea break, start studying, lunch break, start studying, tea break, start studying, dinner break, then sleep. Then you will pass. If you will follow this pattern in these 25 days. That Orbit score that I have told the formula of Bhag, okay? That's you must remember if anyone can see, okay? So that's you must go through the Orbit score. That's the new score that is being used nowadays. Bleeding, history, okay, age, and okay, so as blood that's not being used nowadays. What was that? Okay, ECG shows atrial fibrillation. Which of the following is the most appropriate first line management in this patient? No, that's what I told Dr. Cream. You can remember from BH double AG park. Okay, and also that 2211 is like that. I have remembered 221113. From here, B for bleeding, H for history, A for age, A for anticoagulation, G for GFR. So that's how you must. Everyone should answer. Okay, good. So as a patient have been at worst, symptoms are worst at 12 hours, but he recalls similar episodes more over last 2 weeks. So that's why it's more than 48 hours. We will only control the rate. So that should be our plan. Any contraindication to beta blocker? Auscultation is normal. That's why we will go for beta blocker. Palpitation and past medical history of mitral valve disease and hypertension. Examination, you note an irregular pulse. Confirm the atrial fibrillation. A decision made to chemically cardiovert the patient. Which of the following drug is most appropriate for this patient? So that's with the heart disease, we will go for amiodarone. Good. Several history of palpitation, she denies chest pain, shortness of breath, or lightheadedness. She has a postmenopausal COPD. She shows atrial fibrillation. Examination observation are recorded as. So in this case, patient is unstable. Okay, so that's why we will go for emergency electrical cardioversion. Good. Okay, next. So age 1, if it is more than 65, then we will give 2 score. History of palpitation, or heterogeneous past history of type 1 diabetes mellitus and hypertension. Okay, insulin, ramipril, given his representation, you're describing coagulation. So that's the age is 65, okay? 65 to 72, I think. Then more than 72. So one for hypertension, one for diabetes mellitus. 65%. Okay. That was age 65 to 74 plus 1, more than 75, age 75 or more plus 2, hypertension, congestive heart failure, previous stroke plus 2. So there are 2 score for age and stroke, transit ischemia. Vascular disease, so that's what. Next, that is about has blood score, okay? I think that is not being used nowadays, okay? Leave it. Aortic dissection, I gave this X-ray in my quiz, so that's very important. You must remember type 1, type A, type B, that involves the ascending aorta, type 1, involvement of the ascending aorta. Risk factor, hypertension, atherosclerotic aneurysm, Marfan syndrome. Marfan and hypertension, these are Ehlers-Danlos syndrome. These are very important risk factors. So there will be chest pain, blood pressure differences, and how much blood pressure differences? 20, more than 20, good. Heart rate less than 60 per minute, systolic blood pressure, that's our target. Type A, urgent surgical replacement. Type B, medically, endocrine ischemia, urgent surgical endovascular. That should be your plan. Is not risk factor for aortic dissection. So you will also do what for aortic dissection, what should be your treatment plan, CT angiogram, okay? That should be your investigation that have been previously asked. Which are the not risk factor for aortic dissection? That is COPD, that is not a risk factor, okay? So that you must remember. So that's the X-ray show the widened mediastinum, observation recorded as red BP. So what should be your treatment? First treatment, tearing pain, that widened mediastinum. Yes, labetalol. Hypertensive urgency, emergency. You must know hypertensive emergency. Blood pressure more than 180/60 with an end organ damage, peptidema, retinal hemorrhage, such as acute coronary syndrome, aortic dissection, pulmonary edema, hypertensive encephalopathy, cerebral infarction. So that's called the hypertensive emergency. Urgency, BP is above 1 without any organ dysfunction. That's urgency management. So your target should be, goal should be to reduce mean arterial pressure by not more than 25%. Within 1 hour, you have to only decrease less than 25%. Okay. Vitolol is the first line treatment. combination, myocardial ischemia infarction, combination of esmolol plus glycerol nitrate, left ventricular failure, pulmonary edema. So nitrate, you can start suspected aortic, you can give the labetalol. Acute kidney injury, phenyldopa is the first line treatment of choice. Severe hypertension in pregnancy, we go for labetalol, then nifedipine, and then we go for magnesium sulfate. So that should be for the pregnant, okay? And the other thing, pheochromocytoma, that alpha blocker, okay? So what's the name of alpha blocker? Pentolamine, yeah. So that should be okay. On examination, you see retinal hemorrhage, blood pressure 190 over TT. So what's your first line treatment plan? Yeah, we will start from labetalol. Same, that is pheochromocytoma. We discussed that what we will give. Pheochromocytoma, we will give the pentolamine. Good. Then is the myocarditis. Myocarditis, you must remember in myocarditis, there will be prodromal viral infection. Okay. In the exam, they will give patient is having flu-like symptom, anything but from 2 to 3 days. Then they will give the chest pain, pleuritic chest pain, and that should be plan. And that virus, Coxsackie B virus, that you must remember. So these are the important things about the myocarditis. Well, prior to the onset of myocarditis, non-specific ST segment, T wave abnormalities, troponin should be negative. It can be positive. Okay. Echo myocarditis can cause global or regional left ventricular motion wall abnormality. That's very important. Echo pending. Motion wall abnormality, global or regional. We will do the supportive care, conventional heart failure therapy. We will follow. Investigation, that is diagnostic endomyocardial biopsy. Which of the following claims is not a typical feature of myocarditis? That's no post-value. That's the feature of. They are asking not a feature. Okay. So read the question carefully. They are asking not a feature. That is tall tentative wave. This is a feature of hyperkalemia. The long QT syndrome we have discussed. Quinidine, procainamide, cetolol. See these drugs. Congenital mutation, phenothiazine. They call the long QT syndrome. QTC is prolonged life, 44 milliseconds in men and women. Mainstay for treatment, unless there is identified reversible cause, is lifestyle modification, beta blocker therapy with implantation of the cardiovertical defibrillator in patients who have had a previous cardiac arrest and those continuing to have symptoms despite beta blocker. So that should be your treatment plan. Genital long QT syndrome. So what should be your, yeah, troponin is high in myocarditis, can be high. So that's the beta blocker for long QT syndrome. Not typical surgery prolonging the QT interval. Okay, so that is inhibitors. Syncope, there can be many causes of syncope. Blackout, exertion, palpitation, loss of suspected confirmed heart failure. So underlying cause is epilepsy, faint, unaccompanied vasovagal syncope, absence of features suggest alternative diagnosis. 3Ps, posture, provoking factor, prodromal symptoms, sweating, feeling warm, hot, or blackout. So that's for the unaccompanied vasovagal syncope. That's the other that can be situational. During maturation, that's very important. Defecation by coughing, swallowing, bloated sinus syndrome, head to one side. Spectic orthostatic, for that can be post-drug, drug-induced orthostatic hypotension. That can be. There will be fall in blood pressure at least 20 millimeter. So that's called orthostatic hypotension. What's that? So that vasovagal syncope. So what's the diagnosis in this case? That's not a heat stroke, okay? Orthostatic hypotension. So lying and standing blood pressure. That the Yoxin said that ECG is also, this ECG is also very important, okay? So flattened inverted biphasic T wave, reversed tick sign, okay? So that's the reversed tick sign. So that's you must remember. Then the pericarditis, chest pain, friction with heel. So that will be lying, standing, lying and sitting, relieving, and pain will be with lying down. Causing pleural chest pain is worse on cuffing or lying spine, relieved with sitting up. So that's very important. So that's called the pericarditis. Spanning nerve, the pericardium trapezius ridge. So that will be toward the trapezius ridge, friction rib, left lower sternal border, globally ST concave ST elevation. That's very important. Okay, they will be global in all leads. Okay, ST segment with PR depression. So that's very important points to remember. So what's that? Is there any risk factor you are admitting the patient? No family history, no smoker, no drinker, respiratory normal, chest test is normal, results are normal, ECG shows up. So that's anything wrong with this patient? No risk factor. So why are you not discharging? Why are you worried? Okay, so patient is fine, so we can discharge. Lateral myocardium, that would be AVL. Okay, so that's okay. So that's the end of session. I will share. Okay, how to remember. Anything? Any question? They are not important, but I will share with you the number. How should you remember? Okay, never asked in the previous exam, but you must remember. So please give feedback about your session, today's session. Okay, so you must work hard and revise all these things. Okay, Allah. Tomorrow we will discuss the quizzes, 3 to 4 quiz. Okay, we will discuss.